So we're happy to have Bruce Gantz, who's the chairman of the Department of Otolaryngology at the University of Iowa, with us today, who's going to talk to us on Bell's palsy and facial nerve decompression. So Bruce, thank you for joining us.
Well, Bill, thank you for the invitation. This is beautiful downtown Iowa City, as John knows. And actually, it's nice and sunny today. But I'd like to thank Ann Maxwell and Bill for putting this together. And, you know, this is the new normal. We hope you're getting back to work. You know, in crises, there's always opportunities. And I think this was one of the opportunities that I think is really a positive movement ahead, is that we're sharing more information. We've never done that before, and we've got the capacity now to do that. And so I hope this continues after the COVID. So I'm going to talk about Bell's palsy. This is a pretty controversial topic, as you know. This is a slide that sort of demonstrates this, and Balance and Dual reported their first Bell's palsy decompression in 1932. And Fowler at the time, who was a very prominent person in the Triologic Society, said that it was, he commented there was controversy regarding the indications for this procedure, and it should only be performed by those that were competent. And I think today that's still the issue. We'll talk about Bell's palsy in general. We know about the guidelines that the American Academy has put in place, and we will try to dissect some of that to figure out how to manage this disorder in 2020. So the patient comes in, they want to know when they're going to be able to get back to normal. This is something that affects individuals differently. This young woman was a commentator, and and she was extremely concerned about what was going to happen with her, because this is her job, was going to be her job. So we all know that the diagnosis of acute paralysis is most likely Bell's palsy in 80% of the cases, and it's a diagnosis of exclusion. And most of you that are on this call have gone through your residency, and we know that these are the issues that we deal with. We want to prevent eye injury, tape the eye at night, use lacrolube, artificial tears. And over the past 20 years, we have been treating people with antivirals, and that's controversial, according to our academy. And we'll discuss the issues, pros and cons about that. But probably the mainstay that most people got when I was in training was prednisone, or an anti-inflammatory. And we follow their progress with a monitoring strategy, and we use electromyography. And we'll talk a little bit about that. The symptoms that tend to rule out Bell's palsy are multiple recurrent paralyses. Now, Bell's palsy is known to be recurrent, but it's not very common. Patients that have slowly progressive paralysis, you need to be looking for something else. Twitching and symptoms that are associated with hearing loss, vertigo, or other cranial neuropathies, that's not Bell's palsy. And I think that Ketterer, who was a proponent of only medical management, sort of sometimes confounded the issue, because he would talk about polyneuropathies and central polyneuropathies. And I think that confuses the issue. And if there's no return of function at 6 months, we usually had better look for something else. Now, saying that, It does happen. You can have a patient that has a Bell's palsy and get virtually no return to function. And I'll show you a case of that. So these are the most common differential diagnoses that you're all aware of. I would say that when we are dealing with herpes zoster oticus, with more severe pain and more severe paralysis, we do not offer facial nerve decompression. The only patients that we would offer facial nerve decompression are those that are severely degenerated in Bell's palsy, trauma, when the patient is cleared. And again, we follow the electromyography results that we'll talk about. In acute otitis media, I would tell people that is a very rare condition and you should treat that medically. I'm sure John and Bill and some of the other people that are on the call have had experience trying to decompress someone with acute otitis media, and it's a real mess. And I would stay away from that. Chronic otitis media usually is a cholesteatoma or another chronic disorder that occasionally you'll decompress them. And neoplasms are very special situations. If it's a facial nerve neuroma, we're not very aggressive, because if you remove that neuroma and you try to graft it, you're going to end up with a severe synkinesis, and sometimes just decompressing it, and it is worthwhile, but not to resect it. And these other common things, I have not seen a case of, well, I didn't put in here, but MS occasionally is in there in that uncommon things. I've never seen a case of MS and Bell's palsy or facial paralysis, but I have seen Guillain-Barré as presenting as bilateral facial paralysis, osteopetrosis, Lyme disease, bilateral. So those kinds of differentials I don't think have changed in 70 years. So the etiology, we know that it most likely is a reactivation of a herpes simplex virus, and there's good data to support that, and there's even a mouse model. And I think the Murakami study that was published in 1996 was verified by a group of virologists, and they felt that the data was pretty substantial, and they did believe that herpes simplex is probably one of the etiologies, not the only, but one of them. So the pathophysiology here has really changed over the years. When Dual and Balance were decompressing, they were decompressing here at the stylomastoid foramen. And as time went on, people were decompressing more and more towards the middle ear. And then Hugo Fish and Estlin, who was a neurologist, got involved with this and demonstrated that the most significant area of compression was right here at what they called the meatal foramen. So this is the internal auditory canal. And this meatal foramen has only a 0.68 millimeter diameter. And I will tell you that it also has this fibrous ligament in that area. And this is probably the conduction block region. So over in this picture of this slide, this is from a patient that Gary Jackson sent to me. This was a woman that had an acute facial paralysis in the 3rd trimester of pregnancy. And then over a year later, still had a total facial paralysis. And Gary operated on that patient because he thought maybe she had a tumor or something. He resected and grafted the nerve. And right here is the meatal foramen, okay? And so what you can see, there is a constriction right here. This is distal in the labyrinthine segment, and this is the IAC. And so there was a definite constriction right at this point, at which Fish talked about early on. And that sort of demonstrates that it's a real phenomenon. And if you have ever decompressed someone with Bell's palsy, you will find that when you open up the internal auditory canal, this area here at the meatal foramen, the facial nerve blocks your view of the superior vestibular nerve. It just sort of fills this whole area. And it gives you that impression that when you open this up, there was a bottleneck. So whether or not you want to decompress or not, that's up to you, but that's probably the area that needs to be decompressed. So one of our problems with facial nerve electrophysiology and electrodiagnostic procedures is that we're actually unable to measure the traffic through the injured area right here, okay? We're down here where the nerve comes out, and we haven't developed a very good strategy to retrograde stimulate the nerve to give us any real information. And so what we end up doing is that we stimulate at the stylomastoid foramen and pick up a response in the peripheral nerves, and we give a guesstimate of how much of that nerve is compressed and how much of it is still stimulable. So that's a problem. You just can't do traffic through the area with EMG. The duration of the paralysis is critical. If you wait until 2 to 3 weeks down the line, when you can do EMG testing, it's too late to intervene, as we've shown in others that we'll talk about. So the other limitation of doing electrophysiologic testing is that when you are trying to determine what stage the nerve is in, we know that we can determine if it's stimulable versus whether it is unstimulable. And that when it's unstimulable, the nerve undergoes Wallerian degeneration, but there is a certain amount of nerve still there in most situations, unless you have neurotmesis where you have a complete transection or a complete degeneration of the nerve. And unfortunately, our testing parameters cannot differentiate between the difference between those two conditions. And that's important, because if someone has mostly axonotmesis, they probably will return to rather good function. Where if they have more neurotmesis, they will have more dysfunction. So the testing has evolved over time. Laumann and Yonkes first developed in the Netherlands the nerve excitability test, and this was a minimal stimulation, and we judged one side versus the other when you turned up the current, and we're all familiar with that kind of a task. Mark May felt that you had to use a lot of current and then judge how much stimulation was on one side versus the other side, and that was called the maximum stimulation test. I think it's really hard to judge the differences when you are stimulating the two sides, how much function there really is. And that's why Estlin and Fish, Estlin was a neurologist at the University of Zurich that worked with Fish, and they developed this strategy called it was originally called electroneuronography, and then it was shortened to electroneurography. And I will say that we still use some parameters of electromyography. We actually put a needle electrode in the facial muscles and have the person make a forceful contraction when we see a complete loss of function and loss of stimulability. And I'll show you why we do that. So the commonly terms of are used to talk about the degree of injury. You can have a conduction block where you just have neuropraxia, but the distal portion of the nerve is still stimulable because the axon is still intact and the nutrients are going through the nerve. If you have a second degree injury, you have a severe enough injury that you have degeneration, Wallerian degeneration distally, but the tubule is still intact, and then nerve can regrow through that, and that's called axonotmesis. And third degree injury is where you have either you're transected or you have such severe injury then the nerve tries to regrow and you get lots of problems at that stage. So we can tell the difference between neuropraxia and these two conditions. Unfortunately, our electrophysiology doesn't tell the difference between neurotmesis or axonotmesis, but Fish and Estlund felt that when you got to a certain point that the percentage of axonotmesis versus neurotmesis shifted, and that's when you had a worse prognosis. And so they looked at, I'll show you here again, they looked at some timing issues that helped them make that determination. So to do the strategy of electroneurography, it's pretty simple. You just have to have an EMG machine with surface electrodes, and these surface electrodes are then used to stimulate one set and to record in the other. They found that the stimulating electrode had to go at the stylomastoid foramen area, and the recording electrode where the most activity was in the nasolabial fold, and they would turn that electrode in order to get the maximal amplitude. So they were only looking at the amplitude of the compound muscle action potential as a measure. So when you do that, you stimulate here and you record here, and you're looking at the positive negative deflection, and you measure that positive negative deflection, and it depends upon the number of the amperage or the voltage that you set the device, and I'll show you how we do that. But every time the patient comes in, you stimulate and record on different days from the normal side and the abnormal side, because you just can't use the measures from one day on the normal side and compare it to the abnormal. The skin changes in edema, fluid, and all those kinds of things. So you have to make certain you do the test on both sides when they come in. So the way we do it is you look at the amplitude and you measure the gain. If the gain is a centimeter per 1,000 microvolts on the normal side, you have to turn up the gain, meaning that it's 100 microvolts per centimeter on the paralyzed side because it's much smaller. So you divide the paralyzed or the normal side into the paralyzed side, take it times 100, and that gives you the percent of function, and subtract that from 100, and that was their convention on how to determine percent degeneration. What that was trying to determine was what percentage of fibers in that nerve that's still stimulable is still viable and able to be stimulated versus the amount that don't. And it's a pretty reliable strategy, and we'll show you some studies to corroborate that. So I said that we also use the timing, and when you start to do this electrophysiologic test, you have to wait for 3 days to 4 days after the acute paralysis, because the Wallerian degeneration takes that long to occur peripherally. And then you just follow it and you determine the percent of degeneration or the percent of function. And if you look at this, this is from Fish and Eslin's work. And they felt that if you were in this area here, depending upon the days post-op or post paralysis, if you were at day 7 and you were 40% degenerated, that was a pretty good prognosis, and you could follow that patient in 3 to 5 days. If you were here at day 5 and you were already down here at 60 or 70%, you better repeat that in the next day to find out if the patient is degenerating. This red line here indicated that was the threshold for Fish to decompress. He felt that, or he and Eslin in their original papers demonstrated that when patients got to be 95% or only 5% function on the electroneurography, there was a significantly worse prognosis for that patient. So he felt that he would intervene before they hit 95%, and that's how the convention of 90% degeneration was the indication for decompression. So I said you can use some timing indications also. We know that if you cut the nerve in this 3 to 6 to 7 day period, you're going to have no function in the periphery. But you might have for 2 to 3 to 4 days as Otolaryngology degenerates peripherally. If you're out here at 21 days and you're still pretty stimulable, that means that you're probably going to be fine. Again, it's this axonotmesis on, are you at before 14 days or after 14 days? In the work that we did, we felt that 14 days was the cutoff if you're going to intervene. Fish originally said 21 days. But I think our results and some of the results from the University of Utah feel that it's 14 days. So when you are going to see a patient with acute facial paralysis and you want to do this electrodiagnostic testing, we do the electroneurography. And then if we get 100% degeneration, you put a needle electrode in the face and you have the patient make a very forceful contraction. And if you start to see some motor unit potentials, it may only be one. That means that the nerve is deblocking and that there is really some function there. And if you have some function, you don't have to intervene and do anything. That patient will do fine. And the reason that you get this blocking effect is that when the nerve is swollen, you'll have different rates of discharge through that nerve. And so when you have these different rates of discharge, it cancels out and you have this phenomenon where you might even have a forceful contraction, but you cannot measure anything at the style or at the compound muscle action potential because it cancels itself out. And so that's why it's really critical and why some people in the past didn't believe electroneurography, because they didn't realize they needed to do this. Keter Adur and Mark May were very critical of electroneurography, but they didn't realize that you had to do the EMG with a voluntary motor unit potential, because sometimes when you had a normal or you had no response, the patient would come back to normal. And it was probably because they didn't demonstrate that there was a deblocking effect going on. Hope that's clear. The other thing that Fish also promoted was intraoperative evoked electromyography to actually demonstrate where the conduction block was. And if you go in and decompress in the middle fossa area, and this is the tympanic segment, geniculate ganglion, labyrinthine, the meatal foramen, and the IAC, you could stimulate out here and get a very good response with a needle electrode in the nasolabial folds or the orbicularis oculi, as you see here. And as you move back towards the IAC, where that conduction block was, you won't have any compound muscle action potential or action potentials at all. So that really was needed to demonstrate where the conduction block is. And if you're going to do decompression in this disorder, I would recommend that you use that to demonstrate where the block was. So in summary, as far as electrodiagnostic, we feel that electroneurography really guides us into whether or not we're going to decompress. And we will not decompress anybody that does not reach 90% degeneration in the first 2 weeks. If I see them after, I don't even do the electroneurography because I know I'm not going to be very effective and I wouldn't offer decompression. Well, there is a strong correlation between the compound muscle action potential and the number of discharging fibers. We feel that the top agnostic testing, which was really popular when John and I were residents, is sort of passé, and you need to do the Schirmer's test to find out if you have a dry eye to make sure that the patient is protected. But you must perform this voluntary EMG if you're thinking about decompressing. If you are just going on the ENOG itself, that's not appropriate. So let's talk about some of the natural history and why there's such controversy. Eric Pedersen from the Netherlands followed over 1,000 patients in the 80s and found, and he didn't treat them with anything. None of these patients were treated with any steroids or anything. And 71% came back to normal, 13% with slight impairment, and about 15 to 16% had some dysfunction. And that's probably the reality of Bell's palsy. And maybe now that we're using antivirals, it's not this large of a group that has contracture and severe dysfunction. We know that there have been double-blind studies. This is one by Ketteradur at in San Francisco, and he showed that acyclovir plus prednisone was better than prednisone only. And this is very interesting because Kettera didn't just include people with just severe grade 4 or 5 or 6 paralyses. He included all comers. And I'm going to show you in a few minutes that there are some studies that say that prednisone and acyclovir aren't any better than prednisone when you include all those categories of patients. And he didn't put the ENOG results in there because he said they were inconsistent. And again, Kettera never did the EMG if the patient was severely degenerated. So now let's move to the guidelines. And this is what was published by the American Academy. And I think there are some really good things about these guidelines. Etiology, history, and physical, that, it usually tells us if there's any other symptoms, and if there's no other symptoms, then it's most likely Bell's palsy. They said that we shouldn't get lab testing, blood testing, and importantly, that we shouldn't image these people right away if they've got a history consistent with Bell's palsy, because it's not going to be very helpful. That doesn't say that you shouldn't do imaging, but in our, the way we manage it, we wouldn't get imaging until a few or 6 months down the line if you didn't get any function return, because it probably wouldn't make much difference in the management strategy. Oral steroids, very strong. Antiviral, an option. Should be in combination if you're going to use it, but it's an option. Electrodiagnostic testing or eye care strong, electrodiagnostic testing, an option. And no recommendations as far as surgical decompression, acupuncture, and physical therapy. So they felt that if you're going to decompress them, it was more risky to the patient if you decompress them rather than you leave them alone. So, you know, that's their opinion. So let's look at these two issues a little bit more and look at the literature. And first, let's consider the antiviral treatment. So there has been quite a bit in the literature in the last 10 years about antiviral versus prednisone only. And this study was published in the New England Journal in 2007 by Sullivan and his group. And he did a randomized, double-blind, controlled trial on patients with Bell's palsy. And they were assigned to receive 10 days of treatment of prednisolone, acyclovir, both agents, or placebo. And they measured their outcome on the House-Brackman scale, which is good because this is a group of medicine docs. And they had a large number of patients, 496. So House-Brackman results, 1 or 2 through 6. At 3 months, prednisolone versus placebo, there was a significant improvement with the people that received prednisolone to return to normal or near normal. Acyclovir versus placebo, not much difference. Prednisolone plus acyclovir, not, you know, if you look at it versus the prednisolone, it wasn't really that significantly different. At 9 months, again, prednisolone and acyclovir, not much difference, or the prednisolone and the acyclovir, not much difference than the prednisolone alone. So they felt their conclusion was that early treatment with prednisolone significantly improves the chances of complete recovery at 3 and 9 months, but there was no evidence of benefit from acyclovir alone or acyclovir plus prednisolone in their study. So then a group, these two people wrote an editorial in the New England Journal and showed that maybe they aren't completely correct. And what they quoted was that there was a group of patients that had more full recovery if you had treated with valcyclovir and prednisolone if you had severe paralysis. And it didn't make any difference in paresis. And I think that is the problem, is that in the Sullivan study, it was all comers. And the Hato study that they were comparing it with showed that they separated out the people that had severe paralysis, grade 5 or grade 6, from those that just had paresis. And in the group that had severe paralysis, actually the valcyclovir plus prednisolone or prednisone actually did show a benefit. So they thought that those patients that had severe paralysis should be given the combination. Then in Lancet at about the same time, a group, Alexander de Rua, and I think these are also from the Netherlands. They also concurred with Engelstrom, who made that other report, that you should use antivirals if the patient has severe or complete paralysis. And I think that is really important. And I'm surprised that our academy did not want to differentiate that when they developed their guidelines. So I'm pretty critical about that. So I think that there's another study that was done by Lee, also from Korea. And he felt that the antiviral plus steroid treatment did improve the results in those with severe paralysis. And he found that those people that came back to grade 1 or 2 with steroids only was 66%. And if you use the combination, it was 82%. So that is pretty similar to the HATO study. And so I think it reinforces the fact that we should be using the combination of steroid and antivirals when we see these patients initially. So what about surgical decompression? Well, this used to put 2,000 to 2,500 people in a room at the academy and at the trialogic meetings year after year, as Mark May and Kedar Adur duked it out on the stage, with Mark May saying that everybody needed surgical decompression, and Kedar Adur was just the opposite and said there's no benefit. Well, Fish and Estlin popularized the ENOG, and then Fish went in the early 80s and wrote about his surgical decompressions and in his indications, and he felt that people that you decompressed did better than those that you didn't decompress, specifically those with some more severe degeneration. This study was criticized because it had a small number of patients and it didn't reach statistical significance. Then at the trialogic meeting in 1985, I was actually sitting in the audience. Mark May gets up and said that he felt that his mastoid decompressions were of no benefit. And all of a sudden, the room just went quiet. And after that, the number of people that we saw in otolaryngology that had acute Bell's palsy just plummeted, because there wasn't anything we could do for them. We weren't going to decompress them. So about that same time, I was a naive young faculty and I had just come back from Zurich and decided that maybe we could reproduce the study that Fish had done initially. And we wanted to make certain that we were identifying the correct people that might have a poor outcome. And then can we prevent those poor outcomes? And does surgical decompression of just the middle fossa, which would include the labyrinthine segment, the meatal foramen, geniculate ganglion, and a little bit of the tympanic segment that you could do from above. Was that really worthwhile? And then the fourth issue that we were trying to address was, is it going to really be helpful, and is there a critical time period? So we got a number of my colleagues to say they would put patients and do this. We did not randomize it. It was not blinded. But I will tell you that, as I'm going to show you a little bit later, this is sort of an orphan disorder, and you really can't get enough patients to do a randomized trial for this. This study that we did, it ended up at the University of Iowa, the University of Michigan, and Baylor College of Medicine, John Kemick at Michigan, and Herm Jenkins and Newt Coker at Baylor and myself were the ones that actually put patients in the study. And it took us 15 years to accumulate a significant enough number of patients, which weren't large, but enough to be significant. So we decompressed through the middle fossa only on patients that had greater than 90% degeneration within the first 2 weeks. We originally started with 3 weeks, and then we went to 2 weeks. And we do have some that were done at 3 weeks, and they actually are a nice surgical control. And we decompressed this area here, all 3 sites, and we followed our patients over time. We also did EMG, voluntary EMG, before we decided to operate on them. We followed a large number of patients that didn't reach 90% degeneration. And I don't know if I can move this out of the way here. There were 169 patients at Iowa that didn't reach the degeneration. And only 19% degenerated in that group. So there were 81% didn't get decompressed. So of that 32 patients at Iowa, we treated 11 with steroids only. We decompressed within 14 days, 19, and they had, and 2 of those we didn't get follow-up on. And we decompressed 7 after 14 days. So that's sort of a surgical control. Let's see. Now, the steroid only, if you followed that group at Iowa and Michigan, the Baylor group didn't follow those along like we did. 89% ended up with grade 1, House-Brackman, at 6 months. And 11% were grade 2. We had no 3s and 4s in that group. So the patients that we had that were greater than 90% and treated with steroids only, you can see we had none that came back to 1. There were 5 at Michigan, and 10 and 19 were 3s, 10 were 2, and a couple at Michigan were 4s. So our decompression group, this is all of the patients that were decompressed, and we had, these all had greater than 90% degeneration and were decompressed within 14 days and had no voluntary motor unit potentials. So 14 came back to 1, 17 to 2, 2 at 3, and 1 at 4. And this was compared to the steroid-only group of patients. And as you can see, 91% of this group ended up with 1 and 2 for middle fossa decompression, and 3% poor outcome compared to the steroid only. And this was highly statistically significant. And you can see here that it was at 0.0002. So that was highly significant. Oop, I'm not moving. All right. So, and I will tell you that the group that we decompressed after the 14 days that we did at Iowa, there was no difference between those and the steroid-only group. We didn't have anybody that came back to grade 1. I think we had 1 that came back to grade 2, and the rest of them were grade 3. So I think that in summary, ENOG and EMG really do identify that group of patients that may do poorly in the first 14 days. If they don't reach that degeneration, they've got an excellent return to grade to House-Brackman 1, and only a few were at House-Brackman 2. The treatment of the poor outcome group with steroids, only 58% came back, and they had or 58% ended up with 3s and 4s. And so it's probably worthwhile in a group of patients that would like this done. And I sort of tell my residents, this is sort of a cosmetic procedure, because if you don't do anything, they're going to return, but they're going to be unhappy as heck. And unfortunately, when these people come to see us today at 3 months to 4 months later, there's not much we can do for them. So maybe earlier treatment with antivirals would be worthwhile, and we recommend that in this severe group. So there is another study out there besides ours now that corroborates that, and it was done by Cannon and Clough Shelton and Rich Gergel at Utah. They had similar parameters, and they felt that their results at 1 and 2 were 71%, and House-Brackman grade 3s were 28%. And a subset of these patients were decompressed after 14 days, and again, only 20% came back to 2. So it was similar to what we found. So, you know, the O-H&S guidelines, I think, are useful, but I don't think that it's useful when it's talking about antivirals, and I don't think it's useful when it's talking about surgery. I would tell you that I don't think the risk of surgery outweighs the benefit in people that do middle fossa surgery on a regular basis. This is something that is not that difficult to do if you are doing it. If it's 1 or 2 a year, I would say it would be better that you don't do it. Now, this is an interesting editorial that was written by a guy named Jacob Deroux, and it was published in Otology, Neurotology in 2010. And he said that if we dive into the literature over the past 10 years, we come up with one study that attempts to appropriately assess the basic question. This study shows that when patients were given the option to have either surgery or not, the difference between the two groups turned out to be significant. For practitioners of evidence-based medicine, it is easy to devalue a decompression study. And I can tell you that the Cochrane Review disapproves of our study. It was not double-blind or randomized, long inclusion period, varying groups. However, what kind of study does one actually expect with regard to such a rare topic? Rare because this group with such severe degree degeneration is small. We think we lack the necessary expertise in this area to perform the surgery. However, we do want to be able to refer our patients. Would we have the surgery performed if we were the patient? Their conclusion was yes. Yes. The above leads to the conclusion that although all evidence is equal, some evidence is more equal than other. Decompression can, in certain cases, when performed by skilled surgeons, lead to a better outcome than the conservative attitude. So, should the combination of steroids and antivirals, should we use them within 7 days of the onset of the paresis? Yes. Randomized controlled study in Bell's palsy will probably never be completed. And surgery, if it's going to be done, should be done within 14 days. And it should be done through the middle fossa. This is our algorithm. It's on our website, the Iowa protocols. And this lecture, a lot of it is on the Iowa protocols. So This is the way we do it at Iowa, and I would be thank you for listening.